It is my pleasure to ask now Associate Professor Moschos from North Carolina to present to us recent data regarding immunotherapy combinations and beyond.
Ευχαριστώ την Οργανωτική Επιτροπή που με προσκάλεσε να έρθω στην χώρα που με γέννησε και με μεγάλωσε και με μόρφωσε. So the next will be all in English. So melanoma doctors, as I am, have now changed their role in the whole space of immunotherapy. We always kind of lead the way of developing new immunotherapy combinations. This is our role in the world where PD-1 inhibitors and CTLA-4 inhibitors are now well established, and we're looking for the next generation of immunotherapy treatments. I will be talking about drugs that we are currently doing clinical trials at the University of North Carolina, Chapel Hill, and I have these disclosures from pharmaceutical companies. So I'm going to try to talk about a very high top-level view of the immune system, because this is where we have to go back and read and study and investigate in order to develop the new immunotherapy combinations. In my personal view, I will describe only 4 or 5 clinical trials that I personally believe may lead to new immunotherapies in the next 2 to 3 years for the treatment of melanoma and other cancers. And then I'm going to present a few concepts from what we are working on at the University of North Carolina, Chapel Hill, trying to address real clinical problems with immunotherapy resistance and beyond. So this is a very well familiar overview of the immune system for you, and perhaps most of you are familiar with the interactions between an immune cell and the tumor. I want to remind you that not everything is an interaction between an effector T cell and a tumor cell. There are so many other immune cells that play a role, such as the natural killer cells and B cells. So this is much broader interaction that immune cells have or may not have, depending on whether the tumor cell does express antigen presentation molecules due to changes in the expression of HLA of beta-2 microglobulin. There was a nice abstract on RNA expression of about 1,880 tumor biopsies where they used gene expression profiling to look what immune checkpoint proteins and other immune cells are actually upregulated in patients' tumors that either PD-L1 high or PD-L1 low, and you can see other immune checkpoint proteins such as TIM3 or LAG3 that may be present or absent depending on what's the PD-L1 expression in those tumors. We also need to pay attention to what the tumor itself is doing, and there are genetic aberrations that do change the immunogenicity of tumor cells, and that's how we have tumors that are inflamed or non-inflamed. And in addition to genetic aberrations, there are epigenetic aberrations that are coming more into the forefront of research with methylating or demethylating agents or histone deacetylase inhibitors. There was a lot of talk in the previous session regarding the somatic mutation burden, but I also need to emphasize that apart from the global view of how many mutations you have, it is very important to know that certain tumor oncogenes or tumor suppression genes may play a very important role in terms of immunoregulation of the tumor. And these mutations, Dr. Gajewski has described, like mutations in the APC beta-catenin pathway, as well as mutations in the RAC1, which are activating, or EZH2, can really have an immunomodulatory role and therefore dampen recruitment of T cells at the tumor site. There is also now drugs that not only solely target or augment the effector T cells, but also other populations such as myeloid-derived suppressor cells, for which entinostat, which is an HDAC inhibitor, is currently being used and investigated ipilimumab, as we know, does have effects on T regulatory cells. And there are also drugs and conditions that basically affect the thymus, i.e. the organ where a lot of autoreactive T cells are being deleted out or not. There have been reports, for example, that the sex and the body mass index do play a role in the predicting the response to targeted therapies and immunotherapies in melanoma. In other words, obese males with BMI more than 30 may have better response to those treatments than other groups. And of course, we have drugs that do affect the survival of T cells. As we know, there is a big production and survival problem of effector T cells. A lot of these patients do have lymphopenias, which is an adverse prognostic factor for melanoma and other cancers. So this is Tom's and Craig's Singluff classification of melanomas. Tom usually talks about tumors that are inflamed, that have high numbers of tumor-infiltrating lymphocytes, or tumors that are desert, there are no immune cells, but also there is the intermediate situation where there would be only peritumoral immune cells, which for some reason they cannot get inside the tumor. Well, I would like to propose an extended view of this system. That is, the more there is a dysfunction in the tumor microenvironment with respect to factors such as hypoxia and pH, or even availability of metabolites, these conditions may worsen with respect to the immune system. So we completed a study, which was a multi-center study sponsored by the National Cancer Institute, of a drug, ibrutinib, for patients who have PD-1 inhibitor refractory and MAP kinase inhibitor refractory melanomas. The trial was dead negative, so we enrolled 18 patients. But what was the interesting thing to me is to look at these tumor biopsies from archived tumor tissue from those patients before they enrolled into the study. And what I present to you on the color bars is basically expression, protein abundance of the two most frequent tumor suppressor proteins that are being deregulated in melanoma. That's one, P10, and P16, which is a cell cycle inhibitor. Please note that this is expression of proteins, and it's not any genetic aberrations, as we know that these proteins can be epigenetically deregulated, such as methylation of the P16 promoter. What was striking for me to see was that most of these 18 patients have almost absent expression of P16, and a lot of these patients have lower absent expression of P10. And what was very equally important to see was that when the pathologist scored the density of tumor-infiltrating lymphocytes, there was only 2 out of the 18 patients who actually had brisk tumor-infiltrating lymphocytes. And this was also confirmed for the abundance of CD8 cells and CD19 cells, suggesting that this group of refractory patients to the standard of care treatments is a very dysfunctional group for which we should try to understand what is going on. So as I said, 70% of those patients' tumor biopsies had no tumor-infiltrating lymphocytes, which is something to consider. I will present 4 examples of what I personally believe would be systemic treatments that may be approved in the next 2 to 3 years for metastatic melanoma, and perhaps these will be extended to other cancers as well. The first one is the concept that targeted therapies, if combined with immune therapies, they may increase responses and overall clinical benefit. This is the earliest report of a phase 2 study of BRAF inhibitor and a MEK inhibitor, dabrafenib and trametinib, plus pembrolizumab in patients with BRAF mutant melanoma. This is a small randomized study, so you wouldn't expect considerable clinical benefit, but you can see that perhaps the addition of pembrolizumab to the dabrafenib trametinib may not significantly alter overall survival or even the response rate. So there are at least 3 to 4 trials that are currently ongoing, phase 3 trials, to test whether the addition of pembrolizumab will really make a difference in progression-free, at least, and overall survival in those patients. The second example is the anti-LAG-3 monoclonal antibody that BMS has, which in this phase 2 study showed that in patients with PD-1 inhibitor refractory melanoma, if given with nivolumab, it does have response rates, which on the left side you can see they may be related with the expression of LAG-3 in the tumor. These responses appear in this very early phase 2 trial to be durable for this refractory population, and the phase 3 study is ongoing at this time. Adoptive cell therapies are beginning not to be the privilege of a few academic institutions who can actually harvest tumor from the patient, then ex vivo expand the lymphocytes, and then give them back to the patient. So now there are companies that actually are doing this for you as long as you provide them tumor tissue. So Iovance, prior line pharmaceuticals, has been doing this study in which 60 patients were enrolled, of which 47 were able to produce a product. And these patients were refractory to PD-1 inhibitors, most of them to CTLA-4 inhibitors and other targeted therapies. And these responses, there appears that this group does have responses, and these responses are durable. At the same time, there is a treatment at the US of high-dose bolus IL-2, which is a very toxic treatment, and it's FDA approved for renal cell cancer and melanoma. And this, again, is a privilege only of a few very specialized academic institutions who can give this toxic treatment. It appears that various modifications of IL-2, such as pegylation, may actually have a clinical benefit, and this treatment can now potentially be given in the outpatient setting. So this is the early reading of a trial that administers the compound termed NECTAR-214 in combination with nivolumab in patients with PD-1 inhibitor naive metastatic melanoma. I need you to be aware that this is in the naive setting, which is what the company decided to do. But nevertheless, the responses are very high, and it's my understanding there's a phase 3 trial going on right now in metastatic melanoma. So since 2013, when PD-1 inhibitors were becoming a real deal in terms of their approval for melanoma and other cancers, I was personally very intrigued by how costly these drugs are. And it was very amazing the fact that we do have biomarkers of response to target therapies, but we don't have biomarkers of response to immunotherapies. So with all the problems of PD-L1 testing with respect to sampling and how big of the tissue is and where it comes from and so on and so forth, we were thinking at the University of North Carolina to develop a non-invasive biomarker. At the time, we approached Merck, and they were receptive to the idea of using a novel PET tracer that targets the tryptophan pathway because they had their own IDO inhibitor, and there was an ongoing study with epacadostat plus pembrolizumab. So the strategy for development of molecular biomarkers in oncology has to balance between the biomarker highlighting the fundamental defects of the immune system and the need to show essential specificity for the target. There are multiple non-invasive biomarkers right now in development that may, for example, track CD8 cells or their function like cytotoxicity. And we felt that amino acid PET imaging would be another way to do this. I showed you the extended view of what tumors look like. So the more dysfunctional the microenvironment is with depletion of metabolites, that may starve immune cells from essential nutrients for the survival and activation and killing against tumors. So there is this evolving concept that immune cells may not like to stay in an acidic microenvironment where there is no sugar, there's no pH, and there's not essential metabolites. There are essential amino acids, including tryptophan, that if depleted from the immune cells, they will not be activated and they will be apoptosed. So what we did was basically getting the tryptophan structure and methylate the alpha position with a carbon 11. This is a very short half-life. But the reason we used this alpha-methyltryptophan is because it has been previously used in patients, in humans, and FDA would allow us to use this non-invasive PET tracer to predict response to immunotherapies. So this is what we used, the alpha-methyltryptophan, and we soon realized, although we thought that this was only highlighting IDO expression in the tumor, that it basically highlights the entire tryptophan metabolism pathway, which is more complicated than that of IDO. So what we would do is we would measure the standard uptake value of these tumors and try to correlate the standard uptake value with response to pembrolizumab. So this was our trial hypothesis. If tumor-infiltrating lymphocytes are not present, they probably are not present because they starved from essential metabolites, including essential amino acids like tryptophan. So in tumors that are cold, so they don't have a lot of tumor-infiltrating lymphocytes, perhaps the metabolism for this particular amino acid is so high that the immune-infiltrating lymphocytes, they cannot keep up with their uptake because all of this is taken up by the tumor. And in so doing, then basically the cells will not be activated and they will die, and therefore they will not be present in the tumor. Whereas the opposite would happen in the cold tumors. To me, it's something like this. So you have basically your cup of coffee and there are two straws. One straw, the large one, is the one that the tumor handles, and the other straw, the smaller one, is what the stroma has. So if you have the largest straw, you would be able to starve and take the coffee more, and then you're going to leave less for the one who's going to sucking up from the black straw. So we had a very simple concept. We would like to image the tumors with this novel PET tracer, and we would simply just give them 4 infusions of pembrolizumab and see whether the uptake of the carbon 11 alpha-methyltryptophan would correlate with response or resistance to immunotherapies. So as of November, we had 16 patients, and we were pleased to see that this was a mixed bag of responders and non-responders. And as you can see, a lot of these patients did continue on pembrolizumab, as you can see from the blue bars. Other people went on to progress and have resections and going to other drugs. So this is the results from the first 16 patients, and you can focus on the column number 5 and 6, where we have imaged those patients with FDG PET imaging and with C11 imaging at the same time. And as you can see, the standard uptake values for C11MT are relatively low, but they do not fully correlate with the expression and the SUV values that we take for FDG PET. In fact, I have highlighted individual tumors where the SUV high, maybe the FDG PET SUV may be very high, and the C11 alpha-methyltryptophan is low. So it looks like, at least from these early 16 patients, that the C11 alpha-methyltryptophan is giving you a different signal from what the FDG PET does. And what seems to be the case, and again, we don't have a whole lot of tumors and patients yet, the trial is going to accrue up to 25 patients, is that the higher the standard uptake value of C11 alpha-methyltryptophan predicts resistance to PD-1, to pembrolizumab. And the question is, why high C11AMT can regress in contrast to our hypothesis? And I provide you 3 examples of 3 tumors from 3 patients who, all of them, the first 2 actually had progressive disease, and the last one had stable disease. So as you can see, the tumor is metabolically heterogeneous with respect to what's happening with respect to tumor metabolism of tryptophan. So therefore, clones with SUVs that are high, relatively high, perhaps would otherwise be present in other parts of the body. And therefore, although the tumor may overall shrink, there would be areas of the tumor that are actually still active. And this is what you actually see in patient number 110, where most of the clones have a very low SUV uptake of the C11 alpha-methyltryptophan, and only a few clones are very high, in contrast with patient 107, who has very high numbers of clones within this tumor that have high standard uptake value. So the question is, where does the high SUV signal come from, or why do we even care? We care because there was a recent study of pembrolizumab plus epacadostat that was dead negative with respect to progression-free and overall survival in patients with PD-1 inhibitor naive metastatic melanoma. And it was quite shocking to almost everybody because they thought it was very certain that IDO inhibitors would be rationally combined and be more effective than single-agent PD-1 inhibitors. And what we did was we went to 88 biopsies from patients with metastatic melanomas, and we essentially stained them for all the enzymes that were possible, and they are used by the tumor to metabolize the tryptophan. So there's not only IDO1, but there's also TDO2, there is tryptophan hydroxylase 1 and 2. And also we stain them for the transporter for tryptophan across cells. And I think what you can see on each and every enzyme is on the upper part of each graph is the blue, which is the expression of each of these enzymes and the transporter in the tumor-infiltrating lymphocytes in the tumor. And on the red dots, you will see the expression of these enzymes in the melanoma cells. And I think you immediately see that across all different, the 4 enzymes and the 1 transporter, that melanoma cells do have higher expression of enzymes in the transporter. And in fact, IDO expression is relatively very low, whereas the expression of other enzymes like tryptophan hydroxylase 1 and 2 is relatively high. So perhaps the metabolism is coming from the tumor, from TPH1 and TPH2. Why do we care? We do care because there are actually FDA-approved tryptophan hydroxylase inhibitors, which is one that we were happy to see that the company Lexicon Pharmaceuticals is interested to use the tryptophan hydroxylase inhibitor in combination with pembrolizumab for patients with refractory PD-1 melanoma. I was very happy to see Dr. Kramer talking about the role of normal antigens in enhancing immune response to cancer, because we strongly believe, and I believe that melanoma cells and melanocytes share quite a bit of normal antigens. So a lot of these immune responses are not because of neoantigens, but they're also because of the normal antigens. And you should not all forget the fact that the early era of melanoma immunotherapy was the result of all these melanoma vaccines that were developed in the 70s, 80s, and 90s. And guess what? These were all vaccines against normal melanocyte antigens. In fact, when Catherine Hoadley, our bioinformatician at the University of North Carolina, interrogated the Cancer Genome Atlas Project for the RNA expression of normal melanoma antigens, she found that across all different groups, there were these patients who had high expression of normal melanocyte antigens, suggesting that melanoma cells, again, expressed high numbers of antigens that are normally seen in melanocytes. So I would propose that there would be 2 important strategies to increase host immune response to autoantigens. The first strategy is to allow for more autoreactive T cell clones to escape negative thymic selection. So a lot of autoreactive T cells that our thymus would kill would never reach the periphery, and they would never have a chance to join T cell clones against neoantigens and therefore fight against melanoma. The other way to do this is to allow for more melanoma-associated antigens to be highly expressed by the tumors. Probably a complementary strategy to what Dr. Kramer said about inducing more normal antigens and stimulate immune response. So more normal antigens would be more opportunities for autoreactive T cells to kill, and perhaps by changing the gene expression program, there will be a normalization of immunogenicity of the cancer cells. So going back to your medical school, where the thymus is essentially the filter for almost all the autoreactive T cells, but the real T cell, that the real part of the thymus where this selection happens is regulated by the protein called AIR, which stands for autoimmune regulator. Dr. Maureen Su, who has been a very wonderful collaborator, and unfortunately she left for the University of North Carolina, she's been a pediatric endocrinologist caring about these autoimmune endocrinopathies, and she identified that AIR is actually under the positive regulation of RANK. And guess what? There is already a drug FDA approved for bone metastatic cancer, and that's called denosumab. So what she showed is that if you inject melanoma-bearing syngeneic mice with RANK ligand inhibitors, and then you go after with anti-PD-1 and anti-PD-1, then these mice that get the triple combination have a better response and survival compared to mice that get only CTLA-4 and PD-1, and that these mechanisms actually regulate at the level of the thymus, allowing for more autoreactive T cells to actually to go against these normal melanoma antigens. We also show that in patients who were part of the ECOG E1608 trial, the cooperative group trial, where all patients were treated with ipilimumab, and those who had the polymorphism that's associated with autoimmunity had higher responses compared to those who did not. But unfortunately, the polymorphism of AIR that leads to low AIR levels and therefore more proneness for autoimmunity is only present in 5 to 7% of normal individuals. So we propose that denosumab would actually lower the autoimmunity threshold, allowing for more autoimmune cells to go against the cancer. So we opened the study of denosumab in combination with nivolumab. In that study, we prime the patients with 2 injections of Xgeva, and then we do a mandatory biopsy on day 22. In that case, we envision denosumab to be more of another of immune checkpoint regulator, and we would be looking for the thymic output from the thymus, as well as changes that denosumab does at the tumor site. We actually have already 3 patients enrolled into the trial, and this is the results of a patient who was our first patient who had 85% shrinkage. I do accept the fact that this could have happened with single agent PD-1 alone, but therefore this was a pretty impressive shrinkage within 2.5 months by getting denosumab and Xgeva. I will stop here by talking about modulating gene expression by histone deacetylase inhibitor, as there is already a study in patients with PD-1 inhibitor refractory melanoma that has shown that there are 20% responses in patients with this multi-refractory population, and these responses are durable, and that the mechanism of this, based on tumor biopsies at baseline and day 21, are due to the result of increased influx of immune cells infiltrating the tumor, which is the purpose one of another trial that we're starting at the University of North Carolina. We're trying to identify which are these patients, the 20% of patients who are actually responding to HDAC inhibitors based on a novel assay that looks for chromatin. I will conclude with the following, that immuno-oncology is not so much more than immune checkpoint inhibitors, and there are probably adoptive cell therapies, IL-2, and drugs that target the thymic tolerance that would be hopefully added. We have to think about the targeted therapies are not those old-fashioned drugs, that they targeted therapies do target fundamental defects of the immune system. It should be considered in combination with immunotherapies. And also our obligation to the healthcare system of all over the world not to break the system just because of all these expensive drugs and attempting to develop new biomarkers, non-invasive, for responsive therapies. Thank you very much.
Thank you, Stergios. Before I'm asking if there are any questions, thank you for this excellent talk. Just to remind the audience, for those of you who weren't there 2 years ago, Stergios Moschos has finished university in Greece, And I've known him since year 2004 when we were first introduced during the Olympic Games. He's a Greek expatriate that has worked very, very hard up into the ladder with too much translational research. We are honored to have Stergios here. So thank you, Stergios, for all your great work. Do we have any questions?
I have two questions with respect to this thymic targeting. First of all, if I remember well, the presence of vitiligo after immunotherapy is correlating with therapeutic responses, which is an argument in favor of positive autoimmunity. So does the polymorphism in air that correlates with the clinical outcome of immunotherapy also increase the frequency of vitiligo in patients?
Never looked at that. We are short-staffed with respect to, we can do a simple thing like going to the Cancer Genome Atlas project, and basically we have 470 patients, and we can actually look for the polymorphism of air. And actually, I would bet that this correlates with survival. So not even without any treatments. But vitiligo and correlation with air has not been investigated. Air is an autoimmune regulator, corresponds to a disease that actually induces polyendocrinopathy. So a lot of endocrine organs are affected, not vitiligo.
And the other question is related to thymic atrophy. So in the clinical trial that you're designing that involves the inhibition of air indirectly by giving a rank ligand blocker, would you introduce as a predictive biomarker the size of the thymus that is depending on age, on glucocorticoid treatments?
Yeah, yeah. So we're looking for needle in the haystack. So we're looking for events in the blood that are like less than 0.5%. So we're looking for recent thymic emigrants and outflow and Tregs and all that stuff. Every single time point we collect blood, we collect 100 cc's of blood. So we collect a lot of blood to look for these events. Obviously, we cannot get thymus biopsies, especially because most of these patients are 60 and 50 years old. But this is what I want to show you. That is, like we're looking for these populations that are so difficult to identify, such as the precursors to the thymus. So is it the bone marrow dysfunction, which I think it is? Is it also a thymic output, which I think it is? So these are very rare ones, and that would be the biomarker that we are looking for.
Thank you.
Stergios, I want also to ask a question because you touched upon the negative trial of ASCO. So what is your interpretation for these negative results with the IDO inhibitor?
What my impression is that my impression is there are two faults here. Companies should never introduce a drug in melanoma without going through the stage of testing this in the refractory setting. So Nectar 214 is actually going under threat right now because they want to do this. Second, the biomarker that was selected to use for IDO inhibitor was based on a serum assay of serum kynurenine levels. That's how they selected the dose of epacadostat. That was a no-no for me to do that because people need to look at the tumor tissue about what is going on. The coffee with the stir and the big and the small straw, I think is a real deal. And there will be more and more of these drugs that actually do target the tumor microenvironment and would be about metabolites, availability of this. So it seems that the IDO is not playing a big role by melanoma cells, and there are other enzymes that are more important than that.
Thank you very much.